Welcome to Conversations in Interventional Cardiology. My name is Suzanne Baron. I'm a deputy editor at SCAI, as well as interventional cardiologist and director of interventional cardiology research at Mass General Hospital. I'm honored to represent SCAI and JSCAI's editor-in-chief, Dr. Alexander Lansky, today. And we're here to discuss a recent article that was published in JSCAI titled Cost Utility Analysis of Endovascular Ultrasound Renal Denervation to Treat Resistant Hypertension in the United States. I am joined by an esteemed panel of leaders and experts in the field. Dr. Rod Taylor, who's a professor of population health research at the University of Glasgow. Dr. Ajay Kirtane is a professor of medicine, director of the cath lab at Columbia University. So without further ado, I will turn it over to Dr. Taylor to start the conversation.
Great. Okay, so thank you very much for the opportunity to give this presentation this evening. And of course, one has the pleasure of making these presentations, but behind that presentation, there's a great team. So I just want to acknowledge and recognise the team, and indeed, Professor Ajay Kirtane is actually joining me today. So my thanks to the team for all their hard work on this. So I am not a clinician. As you've heard from Suzanne, I'm a methodologist, statistician, and health economist, but maybe just a little bit of clinical background here. As I'm sure very familiar to this audience, what we're particularly focusing on is a subgroup of hypertension, resistant hypertension. In other words, people who, despite antihypertensive treatment, are not being well managed. In this population, the Radiance HTN TRIO trial, led by Ajay and colleagues, was a US-European multi-center study looking at endovascular renal nerve denervation. And the question was, is it effective in lowering people's systolic blood pressure in this resistant hypertensive population? That paper's been published in the Lancet, and the aim of this study was to move on and say, well, using that clinical data where we demonstrated clinical superiority of ultrasound RDN, is this a cost-effective approach for the United States compared to what would be standard of care, which would be antihypertensive medication alone? And this graphic here on the right-hand side is just an attempt to give you an indication of the mechanistic basis of the technology. So I know this audience are not economic modelers, but just to say that this is an analysis based on what's called a Markov model. This is the schematic. And really the key thing to say is that people enter this model with their resistant hypertension. And then, as you can imagine, if you were thinking about people's disease pathway, a number of clinical things happen to them. So end-stage renal disease, cardiovascular disease, and we populate this model using real-world data and clinical trial data. And to that effect, you can see that the sorts of outcomes we're particularly focusing on using existing risk equations and the relationship with blood pressure, no surprises, stroke, cardiovascular disease, and also, of course, mortality. So how did we specifically populate this model? Well, first of all, the model was based on the Radiance TRIO trial, so 136 patients with resistant hypertension. And the base case analysis I'm going to show you today is based on the trial result of a 8.5 millimeter reduction in office systolic blood pressure in the ultrasound RDN group at 2 months follow-up. Whenever one does these models, very important that one sources costs and healthcare utilization in the context in which it happens. You can imagine different healthcare systems, different costs. So we sourced US specific costs here. And as I'll present you, the results are what are called in the form of incremental cost effectiveness ratios. I'll explain that in a little bit more detail. And in the United States, effectively, we would be willing to pay for technologies from 50,000 US dollars to 100,000 US dollars per quality adjusted life year. So what we're doing here is converting all of these clinical events into effectively two parameters, length of life and quality of life, and then summating those in a QALY. And the QALY is a very standard metric that we use with policymakers to make decisions around affordability. This analysis is over the patient lifetime, and when we do these analyses, we need to discount both costs and outcomes. So we do that at 3% here. And then, of course, with any mathematical model, there's always going to be some degree of uncertainty in the model parameters. So I will show you again how we've exposed this model to what might be the key uncertainties here using sensitivity and scenario analysis. So here's the first result, and this is our base case result. Might be easiest to look at the graph first. So what we've got in blue is the ultrasound RDN group plus standard of care, and then the comparator group is standard of care alone. So as I say, this is over the lifetime, and there are two outcomes shown here. Life years, which are the first two bars, it's the number of life years that any patient would, on average, experience in the two arms of the model, and then the QALYs. So what can we conclude from here? Well, you can see that the blue bar is exceeding that of the grey bar. So we've got evidence of a delta, an improvement in life years of 0.71, and similarly, an improvement of 0.59 in quality adjusted life years, or QALYs. So we can then use that data to then say, well, how does that compare to the difference in costs? So if we go down to the table, again, we've got two parameters, one in blue for ultrasound RDN, and you can see, not surprisingly, this is a technology with an upfront cost. Yes, we can reduce healthcare utilization, but you can see that on average, the device group had an increase in costs of $7,600. So what we do is to take the difference in the clinical outcomes, and then we can express those as incremental cost effectiveness ratios, or ISRs. And when we divide 0.59 or divide 7,600 by 0.59, we end up with an ISR here of 12,900 US dollars per QALY. This is the base case analysis. What we can then do is to say, okay, well, this is our average result. How might this result look if we were to apply different scenario analysis to the data? So the scenarios we applied here were, in this case, 6 different scenarios. So if you remember, our base case scenario was a reduction in blood pressure of 8.5 millimeters of mercury. Let's say that that was only 5 millimeters of mercury. What happens to the ISR? No surprises. You can see if the treatment effect is smaller, we'll get less QALYs for broadly the same costs. So the incremental cost effectiveness ratio is slightly higher. And again, we can expose it to a variety of different assumptions. So what happens if the effect size was bigger? So we did a subgroup analysis looking at just the US patients. They actually had a larger treatment effect than Europe, 9.6 millimeters of mercury drop. And I'm not going to go through all of these slavishly, but basically we can apply different assumptions around the relative risks of events associated with blood pressure. We took our data from the Thermopolis meta-analysis. Etihad and Rami have published separate analyses. And also we could say, well, look, this is a long time to extrapolate lifetime. What happens if you extrapolated the model just for 20 years? And I think the key summary I would like you to take away here is that all of the ISRs remain well below that US cost effectiveness threshold of $50,000 per QALY. In other words, irrespective of what we throw at this model, it seems that the model is very robust in terms of demonstrating acceptable cost effectiveness in a US setting. Another way of looking at that is to basically put the uncertainty around individual data points, things like the variance, and plug those into the model. And we can then run that model, in this case, 1,000 times, where it's sampling each parameter around that uncertainty. Now, when we do that, we end up with this cloud. So this is 1,000 data points we've run through the model. The x-axis is the incremental QALYs, comparing the two comparators here. And the y-axis is incremental cost. So if you remember, the average that I showed you in the base case is the yellow triangle, and the probabilistic mean, as you can see, is almost identical. The point of this analysis is you can see that this cloud of data, all of those data points lie below, there's the willingness to pay threshold of £50,000 per QALY. So what this basically shows us is that we've got very high certainty from a probabilistic analysis, and actually 100% of our model iterations fall below that threshold of £50,000 per QALY. And we call this a probabilistic sensitivity analysis, just another way to check, are our results robust? So just to conclude then, what does this analysis show? Well, hopefully, as you've seen, adding ultrasound RDN to the existing landscape of antihypertensive medication and lifestyle modification standard of care is be shown to be a cost-effectiveness strategy here in the US setting. And worth saying that we've now run this model analysis in a few different countries. So we've done this modeling in UK, we've done it in 3 countries in Europe, and actually this is a very consistent finding. However, coming back to the US, you know, ultrasound RDN, minimally invasive procedure, but I think given this result, here we have a new technology or a technology that clinicians can use in their tool bag that addresses what is an important area of unmet need for patients, clinicians, and policymakers. And by doing so, can not only be a clinical benefit to patients, but also be a cost-effective one to the healthcare system of the US as well. Thank you.
Thank you so much. That was an incredible presentation and just a wonderful, I think, groundwork to lay for our discussion. You know, one of the things that I really take away from this is when I look at these ICERs, you know, I kind of think of it in comparison to other, you know, commonly used devices in the cardiovascular world and how that compares. So I think about it with TAVR as related to medical therapy that has an ICER that's about $55,000 per QALY gained, or we think about even some of the medications that are cornerstones for what we use to treat, like Entresto, which is $75,000, $80,000 per QALY gained. So I guess what I'll put out to you, given that these are pretty robust findings. So I guess my question to you, Dr. Taylor, and then next to you as well, Dr. Kirtane, is given that this appears to be an effective intervention and a cost-effective intervention, should we be thinking about considering this treatment earlier in the treatment of resistant hypertension?
Yeah. Well, I think certainly from my perspective, I mean, Dr. Kirtane will speak for himself. We've shown that this is a cost-effective treatment in the trial population that we had in TRIO. I think the question of should it come even earlier, I'm going to perhaps duck that one. And as a clinician, I'll maybe pass that one to Dr. Kirtane, because I think, I mean, we haven't tested that in this model, but that would seem quite a reasonable clinical extrapolation here. But one I'll maybe hand over to AJ to respond to.
Oh, thanks so much. And, Rod, great job presenting data. It's not easy to present these types of data in a way that's clearly communicated, and you certainly did that really well. From a clinical perspective, I think the challenge I have personally, and remember, I've been involved in the denervation space for 15 years, and, my conflict is I led these trials, but I'll tell you that, the sum total of patients in the randomized trials that were done with the ReCore device, and you can add the Medtronic device together, is well under 2,000 patients. In fact, for each program, it's close to sort of 500-ish or so in randomized trials. And so on that basis, I have a hard time sort of advocating moving this upstream further. I think that we need the longer term safety data. It looks great thus far. There were no questions whatsoever with either device when it came to safety, but I think we need some longer term data to sort that out. I think the other thing is it's an irreversible procedure versus medications, which are sort of, you take them and then you can stop them. So there's that aspect as well. But I think to Suzanne's point, I mean, this is certainly looking within the stipulations of the models that were presented, like it certainly would help patients from a clinical basis. One thing to just mention as a caveat is that, remember, these trials are based upon extrapolations of what blood pressures would cause in terms of adverse events. These are not measured clinical events within the Radiance Trio trial. And so there is hypothetically this idea that there could be an off-target effect of denervation that's independent from its blood pressure lowering effect. And so that's always something for the clinicians. Now, you want to make sure that there's good prospective outcomes data. But for present, with what the data we have right now, we have to be sure that we do analyses like this to understand it. I think the final criticism I'd point out that people might raise when they look at this analysis is that the analysis is done with a difference from baseline. It's not the sham controlled difference that we're looking at. And the reason we did that deliberately is because when we practice in clinical practice, we don't have a sham. So the sham adjusted difference is important from a clinical trial standpoint, but when we're looking at what happens to patients when they're treated with this procedure, it's really their change from baseline. A baseline adjusted change is appropriate, but that's the change that we think is most relevant.
Yeah. Although important to say, AJ, that we did run the sham control and the scenario analysis and still remained cost effective, because that was one of the strong comments that the clinicians like yourself and the group made, that look, we've got to expose that smaller, more conservative treatment effect. And the fact that we have demonstrated cost effectiveness, I think, is a strength, going back to Suzanne's point here. Sometimes if we just ignored that, I think that would have been a real limitation of this model.
I agree. I think that is something that made this model certainly stronger, to include that scenario analysis. Jumping onto something that you said, Ajay, you made the point of saying that we are making, obviously any model makes assumptions. And what we are assuming here is that a decrease in blood pressure is going to translate to a decrease in MI, a decrease in heart failure, decrease in cardiovascular death. Is there a planned follow-up going on, looking for those kind of hard event outcomes? And if so, will there ever be a plan, and this is for you as well, Dr. Taylor, will be a plan to kind of rerun these models with that updated data?
Well, yeah, I mean, I think we need to continually reassess. And, once you're sort of done with an analysis, it's not, that's the definitive answer. You always will continue to update. So I think, yeah, absolutely, the need would be there to keep looking at this. And some of the data sources are well accepted in terms of where we modeled what the rates of, for instance, subsequent MI and stroke would be at a given blood pressure, et cetera. But contemporary data is always most relevant. And you could also make the argument that patients who will be consenting and agreeing to go through renal denervation procedures might be somewhat different than other patients that are treated with medications. And so I do think it's important to always collect prospective outcomes data. And I think I've been probably one of the few who've been advocating for outcomes data within this space. Everybody was, by and large, super thrilled that these devices met their primary endpoints in clinical trials in terms of blood pressure reduction. But for me, I always take the step back. I'm a clinician. I saw, the reason I was late to this call is I just had a busy clinic with like 25 patients in the office. And for those patients, I think it is on us to really gather the clinical outcomes and to continue to generate more data.
And I think, just to add from me in that, I think it raises two issues for me, Suzanne. So one is, the value of real world data. So we often become very obsessed, and I'm a trialist myself. Randomized trial is king, but here's an example of, well, can we make this therapy available in routine practice, but then follow up people for these real events using routine data? And that's certainly happening in this field. So we're continuing to track these technologies in the longer term. The other one is I guess one that I have seen in a UK perspective, not for this technology, but in other areas where payers are saying, well, you've shown us that this is cost effective based on the surrogate outcome of systolic blood pressure. What we'd like to do is to give you a conditional reimbursement. We'll fund you, but we need to tie you in to come back and show us that these benefits actually do accrue in the future. And I have to say, I think that's such a sensible way to go. I know the FDA sometimes do this with some of their approvals. They'll say conditional to you going on a pharma company or medical device company. And I think, as a taxpayer, at least in a UK setting, or if I was paying my insurance in the US, that might be quite a reassuring thing. So we can make decisions at a point where we have an early result like this, but we protect ourselves by putting some conditionality and an evidence collection responsibility back to the company, albeit to collect that in a real world setting. And I think this is more the sort of thing that we should be doing. So I think it's a great question.
Well, I think that's a perfect way to wrap this up, really kind of bringing into how we should really allow these types of analyses to kind of inform, broader public health and policy discussion around the reimbursement. So this is, I think, a really incredible in addition to the field. I want to thank you both for taking the time to discuss it today and applaud you both on an incredible analysis. Thanks to everybody for tuning into Conversations in Cardiology. We'll see you next time.